Good morning. Today I am going to talk about biology of bone repair or fracture healing. This is a very difficult and very complicated subject. Please listen to this very carefully with full attention. And initially the terms will feel like Greek, but you will get to know about it when you read it repeatedly. There are two types of bone. Normal adult bone is called lamellar bone. Lamella means collagen fibers are arranged in parallel layers. That is a normal adult bone, lamellar bone. There is another type of bone which is formed, that is called woven bone, which is non-laminar. It consists of randomly oriented collagen fibers in adults seen at sites of fracture healing, tendon or ligament attachment, and in pathological conditions. This is the photograph of a lamellar bone, or this is a cortical bone. You know, there are three types of bone cells. One is an osteocyte, one is an osteoblast, and another is an osteoclast. Osteocytes are resting bone cells here. This cortical bone is comprised of osteons. This is one osteon or Haversian system. The name, the same thing, Haversian systems, comprised of osteons. This canal is called Haversian canal. These osteons communicate with medullary cavity by Volkmann's canals. This is another photograph. These are the same resting cells, osteocytes. These are osteon. This is a Haversian canal, and it enters into the medullary cavity by these Volkmann's canals. This is a lamellar bone, trabecular or spongy bone. These are the trabeculae. If you look carefully, these are the trabeculae. It means collagen fibers arranged parallelly. These are oriented as per the line of stress. This is called a Wolff's law. I mean, the axis, the gravity passes through this area, here, then here, the line of weight bearing. That's why you can see on the medial side, posteromedial side of the femur, this cortex is much thicker than the lateral cortex. This cortex is much thicker than the lateral cortex. This is as the body weight goes through this line. These trabeculae are arranged according to the line of stress. And this is a woven bone with random orientation, not parallelly arranged trabeculae. These are much weaker than lamellar bone. This is a stages of fracture healing. You know, this bone is fractured here. This woven bone will ultimately remodeled to a lamellar bone. After some time, these trabeculae will be arranged in parallel sheets, and that will lead to the lamellar bone. A bone is composed of cells which are osteocytes or which are resting cells, osteoblasts, these are bone forming cells, and osteoclasts which destroy the bone. In every tissue in our body, formation and destruction goes on simultaneously, side by side. As you know, in case of blood formation, RBCs form and they die. So this osteoblasts, they form bone, and osteoclasts, they cause destruction of bone. They remove the dead bones, older bones, so that the newer bones are formed by osteoblasts. And the mainly extracellular matrix, other than cells, extracellular matrix is composed of organic 35%, inorganic 65%. Among the organic, collagen are 90%, these are proteins, osteocalcin, osteonectin, proteoglycans, glycosaminoglycans, lipids, and most important, the inorganic 65%, these are hydroxyapatite crystal. You will have to remember this formula of this calcium hydroxyapatite crystals. These are the calcium hydroxyapatite crystals. These are the osteoblasts. Osteoblasts are derived from mesenchymal stem cells. They line the surface of the bone and produce osteoid. This is this pink area, this is osteoid. And osteoblasts, they lie on the surface. And as you see, osteocytes are resting cells. They are situated here. Next is osteocytes. These are osteoblasts surrounded by bone matrix. These are trapped in lacunae. Osteoblasts line the surface. Osteocytes remain inside the osteoid. This is osteoid. Function poorly understood, regulating bone metabolism in response to stress and strain. And these are osteoclasts. These are derived from hematopoietic stem cells. These are multinucleated cells whose function is bone resorption. Reside in bone resorption pits, that is called Hauschip's lacunae. These are osteoclasts. You can see osteoclasts. They remain in Hauschip's lacunae. Parathyroid hormone stimulates receptors on osteoblasts that activate osteoclasts that activate osteoclastic bone resorption. After a fracture, what happens? This is a cortical bone and this is the bone marrow, and this layer is periosteum and the blood, and this is skin, subcutaneous fat, and this is the muscles. This bone ends, ragged bone ends, they damage the periosteum and the muscles, thereby causing loss of blood which accumulates here. This is called fracture hematoma. What are the prerequisites for bone healing? These are adequate blood supply to the fractured fragments, fracture ends, and adequate mechanical stability. You see this, if mechanical stability is not there, the newly formed blood vessels, that is capillaries and arterioles, if there is a lot of movement at the fracture site, those capillaries and arterioles will rupture. That will not take part in bone formation. The mechanisms of bone formation are basically cutting cones, intramembranous bone formation and endochondral bone formation. Coming to this later on. This is a cutting cone, this is a forwarding cone, cutting cone. Primarily a mechanism to remodel bone. Osteoclasts at the front of the cutting cone remove bone. Then trailing osteoblasts which lie behind, they lay down new bone. What happens in a fractured area, in a fractured surfaces, due to the trauma, these bones die. About 2 millimeter of bone on each side dies. And these 2 millimeter of bones have to be removed by these osteoclasts so that osteoblasts lay down new bone. Unless those dead bones are removed, this next step, bone formation, does not occur. Intramembranous or periosteal bone formation. This is a mechanism by which a long bone grows in width. Osteoblasts lay down seams of osteoid that I have said before. It does not involve cartilage, annulage or precursor. Endochondral bone formation, mechanism by which a long bone grows in length. The growing end of a long bone, they contain growth plate, epiphyseal plate. Mechanism by which a long bone grows in length. Osteoblasts line a cartilage precursor. Cartilage means the growth cartilage, growth plate. The chondrocytes hypertrophy, then they degenerate, then they die and calcify. Is that area of low oxygen tension. Then the vascular invasion of this cartilage, that is hypertrophic layer, occurs, followed by ossification, increasing the oxygen tension. The long bones have 3 blood supply. One is a nutrient artery here. Through the nutrient goes inside through the nutrient foramen, nutrient artery. Another is periosteal vessels. Next is metaphyseal vessels. Metaphysis is a part of the diaphysis. Suppose this area is metaphysis. This part is metaphysis. Normally, the major blood supply for the diaphyseal cortex is 80-85%. Plus, of course, the bone marrow is supplied by the nutrient artery. Enters the long bone via a nutrient foramen, forms medullary arteries up and down the bone. Periosteal vessels arise from the capillary rich periosteum, supply outer 15-20% of cortex normally. Capable of supplying a much greater proportion of the cortex in the event of injury to the medullary blood supply. It has been seen that when we perform a intramedullary nailing, the medullary canal is blocked by intermedullary nail, which is a choice of treatment these days for long bone fractures, that is femur, tibia. So how come the blood supply comes? So in that case, when the nutrient artery supply is lost, then periosteal blood supply increases exponentially. The vascular response in fracture repair. Fracture stimulates the release of growth factors that promote angiogenesis, that is new vessels, and vasodilatation. Blood flow is increased substantially to the fracture site. It peaks at 2 weeks after fracture. The stages of fracture healing are basically the 3 stages. Inflammation, this is an indirect healing. I'll come to this, indirect and direct healing. Inflammation, repair and remodeling. inflammation, repair and remodeling. Inflammation is tissue disruption, results in hematoma at the fracture site, local vessels thrombose causing bony necrosis at the edges of the fracture, increased capillary permeability results in a local inflammatory milieu. Osteoinductive growth factors stimulate the proliferation and differentiation of mesenchymal stem cells. So this is, as I was saying, this is a fracture of the tibia fixed internally by intermedullary nail and plus interlocking screws. Periosteal callus forms along the periphery of the fracture site. This is the periosteal callus. This is the periosteal callus, the heap of bone. Intermedullary callus forms in the center of the fracture site, and chemical and mechanical factors stimulate callus formation and mineralization. This is the repair. So these are the bone ends. These bone ends, this 2 millimeter on either side gets necrosed. They have to be removed. Then by osteoclast and the cutting cone, then the osteoblasts come and form bone. This is the periosteal callus. This is the external callus. This is a interfragmentary callus, that is, which lies inside the medullary canal, and it's a medullary callus. This is the steps of repair when the fracture is conservatively treated. Now this woven bone is gradually converted to lamellar bone. Look, gradually converted to lamellar bone. Medullary cavity is reconstituted. Bone is restructured in response to stress and strain, Wolff's law. So yes, there are two types of bone healing. One is a direct primary bone healing, and another is an indirect secondary bone healing. So this is the only tissue in the body which heals by bone. Bone heals by formation of bone only, not through fibrous tissue. Skin heals by fibrosis. So there is one direct primary bone healing and another is indirect secondary bone healing. So far I told you about the indirect or secondary bone healing. What is direct bone healing then? Mechanism of bone healing seen when there is no motion at the fracture site. That is a situation of absolute stability. It does not involve formation of fracture callus. Osteoblasts originate from endothelial and perivascular cells and form bone. This is seen in compression plating, rigid internal fixation by compression technique. A cutting cone is formed that crosses the fracture site. Osteoblasts lay down lamellar bone behind the osteoclasts, forming a secondary osteon. Gradually the fracture is healed by the formation of numerous secondary osteons. A slow process, months to years. That's why we don't remove the plate within 2 years. This is a fracture immobilized by a very rigid plate and screws. This is a compression technique. This is called a compression plate. This is here. It causes direct bone healing. And this is indirect bone healing. This is through callus. What are the local regulating factors of bone healing? These are growth factors, cytokines, prostaglandins, leukotrienes, hormones, and growth factor antagonists. What are the growth factors which regulate the bone formation? These are transforming growth factor, bone morphogenic proteins, fibroblast growth factors, platelet derived growth factors, and insulin-like growth factors. Out of this bone morphogenic protein, this growth factor is therapeutically used in cases of non-union or where there is bone loss. This bone morphogenic, there are 17 types of bone morphogenic proteins or BMPs, but particular 2 or 3 types, they are added locally at the fracture site. The only problem, leading to a faster bone healing. Only problem is they are very expensive. There are some BMP antagonists also. These are called noggin, extra-articular cellular inhibitor, noggin. These are the hormones which regulate bone formation. One is estrogen, one is the thyroid hormones, glucocorticoids. I am not going into the details, that it's a very difficult chapter, I know. So the hormones are estrogen, thyroid hormones, glucocorticoids. If you can remember the name, that is sufficient. Parathyroid hormone that stimulates the osteoblasts, growth hormone. There are some vascular factors. These are metalloproteinases or MMPs, angiogenic factors which forms new blood vessels, and angiopoietin. What are the local anatomic factors that influence fracture healing? One is a soft tissue injury. If there is a massive soft tissue injury like this, the blood supply is completely disrupted. So where from these mesenchymal cells come and take part in bone healing? Interruption of local blood supply. There may be interposition of soft tissue at fracture site. I mean, if it is not perfectly reduced, this soft tissue or this soft tissue may come within this fracture area, within these bones. In that case, this fracture is not going to unite. Or in cases of bone death caused by radiation, there are some cases who underwent radiation. If those bones get fractured, it's very difficult to heal. Thermal or chemical burns or infection. What are the systemic factors that decrease fracture healing? One is a malnutrition. We always check when the patient, elderly patient comes here, we always check the serum albumin. It has to be more than 3.5. Serum albumin less than 3.5 denotes delayed healing. Smoking. Whenever the patient undergoes a surgery for non-union, if he is a smoker or he takes any type of tobacco containing nicotine, the chance of union is much less. This is well documented, evidence-based. The patients are told, suppose patient had a fracture, underwent treatment, either conservative or operative. After 9 months, it failed to heal. Then he comes to the surgeon. The surgeon always says, if you are a smoker or you take tobacco in any form, stop this. Otherwise, even if I operate, your fracture is not going to heal. Diabetes mellitus. Even anti-inflammatory medications. As I said, the primary process is inflammation. So the anti-inflammatory medications, that is NSAIDs, they cause at least a temporary reduction in bone healing. Actually, these patients, they don't, whenever you fix a fracture, after 1 or 2 days, these patients, they do not need painkillers or NSAIDs. More and more NSAIDs and the patient will have a disturbed bone healing. There are some experimental things here. Electromagnetic field. Electromagnetic devices are based on Wolff's law that bone responds to mechanical stress. Clinical efficacy is, well, it has been shown to form bone between two poles, between cathode and anode. But in practical field, when it was started application in, say, about last 40 years, the results are not very satisfactory. Clinical efficacy is very controversial. You don't know whether it's going to work or not. PEMF, pulsed electromagnetic field. PEMF is approved by the FDA for the treatment of non-unions. But, well, the results are not very satisfactory till date. Ultrasound. Low intensity ultrasound is approved by the FDA for stimulating healing of fresh fractures. This is also in somewhat experimental stage. Only the future will tell us whether this will work or not. So in summary, fracture healing is influenced by many variables, including mechanical stability, electrical environment, biochemical factors, and blood flow. Our ability to enhance fracture healing will increase as we better understand the interaction between these variables. So, thank you very much. You'll have to read this again and again to understand. Thank you very much for your attention.